Very good evening to one and all. Welcome all. Welcome back to the today's session. So today we have Dr. Mahavir Ghiya sir from Government Homeopathy Medical College. Welcome you sir. We welcome you all the participants. Over to you Ashika.
Hello. Hello.
Sir Ashika, you can speak. Yeah, you are audible.
So welcome you all to Homeovision webinar organized by All India Homeopathic Student and Youth Association. And today in this live webinar, we are having our speaker, Dr. Mahavir Ghiya sir. He is Professor H.O.D, Department of Repertory from Government Homeopathic Medical College and Hospital, Dethali, Patan, Gujarat. So sir is having experience of 23 years in teaching, and sir has done his UG from Foster Development Homeopathic Medical College, Aurangabad, and he has done his MD from Shri Bhagwan Homeopathic Medical College, Aurangabad. He has done his PhD in Repertory from MUHS Nasik in 2023. He has done his MA in Public Administration and MA Psychology too. He has done certified courses and programs too, which add ons to his additional qualifications. And he has also done researches, so he has a research experience too in sickle cell anemia with homeopathic therapeutics, and clinical researches in AIDS in collaboration with Dr. Peter Chappell from UK. He has done many presentations too. He has publications and article published in index and peer review journals too. So today's topic of discussion will be case processing through experienced format. Over to you, sir.
Okay, thank you. Thank you for my good introduction. And I again thankful for this forum for giving me the opportunity to share my thoughts with the young students. I really like the title of this platform. I hope I'm audible to everyone. Just I need one response. I'm
Sir,
audible to everyone.
आप audible है sir, but here just they can do commenting sir.
Okay. Should I continue?
Sir, please continue sir.
Yeah. So again, good evening to everyone. And this is my little introduction. What I learned is from my patients and my experiences in OPD and discussing with all the students. That experience I am sharing with you. What happened when you come from the college and you just very fresh graduate, we are in a dilemma that where to grow, from where to learn the homeopathic practice. We visit to many of the practitioners. Everybody has its own way of practicing. Then nowadays, many different schools has established. They are also sharing their views, and we are attending so many seminars, workshops, and now today there is a overflooded webinars are also going on. So all the things are clashes in our mind, what to do and what not to do. So I had also passed through all these experiences, and when I just go on visiting one more patient, some failures, many failures, some successes, and as the success go on progressing, some idea get integrated in my mind, and that only I just want to share with you. So I had keep this title, how to do the case processing through by the experienced way. And these are experience means not only my own experiences. Everything is, I'm very glad to say that everything our master has already written in our organon of medicine, and all other stalwarts, whoever they are, who is working for homeopathy, who has written the literature for the future of homeopathy, everywhere we get the traces of all these experiences. So I'm just not telling that these are only my experience, but it are just, they are polished things which are already there in our literature. So in today's webinar, I hope we will learn these things.
Sorry to interrupt, sir.
Yes, sir.
Sir, actually, screen sharing has been stopped, sir. Could you share again, sir?
So it is stopped. Okay.
Yes, sir. Screen sharing is stopped.
Okay. And there now?
Yes, sir. We can see, sir. Yes, sir.
Now you are able to see this screen?
Sir.
Yeah.
Yes, sir.
So our today's objective of learning through this webinar is to understand what exactly the case processing as a total it is needed for homeopathic practice. Then to get acquainted with all the necessary steps required for the case processing. Then we will have a practical understanding of every step of the case processing, and whatever the terminology we are going to use, we should be on the uniform pattern. That what when I mean to say evaluation, when I mean to say analysis, when I mean to say susceptibility, we should be at one platform only. So this understanding should be very clear. This is the purpose of my presentation. In the very beginning, when we take the case, we only know that after taking the case, we will form the totality and we will give the remedy to our patients. This is what we are learning as far as our curriculum goes. And when you enter into the practice, and this used to happen, that whoever patient visited to us, we try to collect all his information, and then immediately we try to form the totality. And then we try to give the remedy for that. This happens with me in initial years for a number of times, but every time we get success, many times we won't get the success. And then when you retrospectively study that what I am doing is everything is right or somewhere a problem is there. And then we try to find out the answer for each and every problem. So this is not enough for a homeopathy, that taking the case, forming a totality and selecting a remedy. There are various steps are there in between these two. From case taking to totality formation, there are various steps and that has to be followed. Then from totality formation till remedy selection, also there are various steps. And after remedy selection, when you give that remedy accordingly to the patient, then when patient comes to the follow-up, that also need to be seen very systematically, and then we can say that yes, it is really done. Now we will try to see the different steps which are coming from case taking till the totality formation. Very first step comes is the diagnosis. Usually we are under the impression that whatever the patient comes to us, we have to take these symptoms, characteristic symptoms into consideration and directly prescribe to the patient. But actually this is not so. Unless and until you diagnose the patient, many times as our diagnosis is not correct about the disease pathology, our approach gets diverted. Just for the sake of more understanding, I will share you some of the photographs. Some of the photographs just recently visited in our daily OPD patients. Are you able to see these photographs, all of you? So the patient is presented with the lesion at this place. It is just an accumulation of blood and it was just an ecchymosis. Just keep it in mind, this picture as a first case. Now the thing is very clear that what it meant. If you take the history, while taking the history, I came to know that her grandson was playing with her, and when he was playing with the bicycle, that bicycle has dashed on her eyes, and their ecchymosis occurs. So our clinical diagnosis, it is just an contused and confused wound only. That is, there was no laceration or any abrasion there, but it was just an ecchymosis over there, just contusion is over there. As usual, when you explore the patient, that what more, then we came to know that this patient has also told that he is also suffering from allergic rhinitis. She is also used to get the recurrent attacks of urticaria. For that, now she is fed up and not taking any medicine. She knows that urticaria will be there, it will remain for one day and then it will disappear of its own. And for this allergic rhinitis, she is very acquainted with that cetirizine medicine and she used to take. Now, in this situation, what to do? We have the patient having 3 diagnoses. One is this injury, second is allergic rhinitis, and recurrent urticaria. Now, what to do? This is the question comes in our mind. Right? Now, we will solve this question afterwards. Just keep this mind that this was the scenario which is happening into the practice. Now, I will share with you one more very interesting data of this patient. So this is the mouth ulcer. I hope everybody is able to see this. Are you able to see this?
Yes, sir.
Now this history of such a ulcer, very recurrent ulcer since almost 2 months. When she applies some medications like Smiley gel or this glycerin, it disappears. And again, after some time, it is appearing again and again. Very obviously, we will thinking of some of the medicines that this is aphthous ulcer, and we will see either borax or nitric acid or anything like that, and we will proceed for giving the medicine. This is second case. You just keep it in mind so that I will share with you that what happens actually into the practice if you are not able to get the diagnosis very clearly. Now, this is the third one, probably the last one. So some white plaques are there below the tongue. Since 2 to 3 months, that was the history given by this patient. We are also thinking some sort of ulcers or some discoloration, depositions, all these things we are thinking of. This is our the primary things at all the time, and we are very sure that we will open the repertory. We will find out what are the remedies which creates a white plaques or white discoloration under the tongue, because it's a very characteristic location is available in this patient. And then we just go on giving medicine and observing that what is happening. But unless and until we fail into such cases, we never start our retrospective learning. Now, coming back to what I want to tell you, that diagnosis is the most important thing. So first, our clinical diagnosis has to be very, very clear. And if our clinical diagnosis is very clear, then it gives path in which direction should I go. So if you recollect our first case where this only ecchymosis was there, allergic rhinitis was there, and urticaria was there. So here, first I have to take care of this acute problem only, that is an injury, not to take into consideration this urticaria and this. That is only going to help me. If I see the second case, it was an ulcer, but just to diagnose only the ulcer is not enough. When I take the history, then I came to know that this patient has put up artificial denture just 2 months before. But that artificial denture was ill-fitted. And because of that ill-fitted, whatever this canine tooth was there, which was all the time piercing that lip, lower lip. And that is why there used to be an ulcer. So my clinical diagnosis is, it is a traumatic ulcer. Now, if it is a traumatic ulcer, I must find out what is the things which is causing the trauma. If it is a recurrent chewing, then for that I had a rubrics in my repertory, that I can prescribe. But now this artificial denture, I can make it by medicine clear. She has to be visited again to the this dentist and make the necessary corrections in that denture, and then again she has to put it. Otherwise, whatever the medicine you are going to give, it is not going to help. So that's why this clinical diagnosis is most and most important for us. As far as the third case is concerned, if you see these white flakes are there, when you take the history, then I came to know that this patient has having the history of tobacco chewing. So if tobacco chewing for a long period of time, it is there, and we are not sure about the diagnosis. The diagnosis of that case was leukoplakia. It was just the beginning of this pre-malignant condition, leukoplakia. So in that, only giving medicine is not enough. We need so many additional things. That first and foremost is to stop tobacco chewing for this patient. If it is needed, go for the biopsy, get it confirmed, so that we can have a good management. Only giving medicine is not enough. We need to go further. So clinical diagnosis don't consider only the naming of the disease. By that we can understand the pathology. By that we can understand the probable etiological factors for that cause, and then all the rest of the auxiliary measurements which we can keep it in mind when after giving this medicine. These are also helping to us. So that is one clinical diagnosis. Then we have many diagnoses as far as homeopathy is concerned. We need to understand the susceptibility of the patient so that we can give the, XYZ remedy in proper dose and potency. Then we need to diagnose the miasm of the patient. Now these miasms we usually consider of the two, that is fundamental miasm and dominating miasm. What I confirmed that we are prescribing on the state of the disposition or the present state of the person. So during that present state, whatever the dominating miasm is there, that is the most important, that we must be able to identify. Now this was the question for many years to me, that how I will identify the miasms, how I will identify. Now here on the from this platform, I'm making it very clear. It is the only manifestation. Only manifestation. Don't consider that ulceration is a syphilitic, overgrowth is a psychotic. Okay, these are the some of the things which our pioneers has been told to theoretically understand that miasmatic things. But if you go for this theory of this chronic diseases, there you will understand it is only manifestations, very peculiar manifestation. Every miasm is having, sora is having, syphilitic, psychotic, they are having their very peculiar manifestation. Might be through modality, might be through some general symptom, might be through some mental symptoms, and whatever the symptoms which are available into the patient, the majority symptoms of indicating any miasm, that to be considered as a dominating miasm for this for the patient. And whenever you select the medicine, take care that miasm should get covered by that medicine. This much is not enough as far as the diagnosis is concerned. Further, we must be able to understand the patient as a person. Many times, though we have the clinical entity pathology well understood for us, but if for that anxiety is the cause, extreme grief is the cause, or any psychosomatic element, if it is working, then we need to take into patient for the counseling for better adjustment into the life. That can remove the maintaining cause or this probable etiological cause. In that point of view, also we need to understand the diagnosis of the person. So diagnosis is very important. Just not only the clinical diagnosis, but these further things to be also kept in mind. So once you diagnose the patient from most of this level, very obviously that clinically we will diagnose. Then comes the most important aspect, that is an analysis of this. And I found that most of our failure in our practice is because of misunderstanding of this analysis of this. Now, what I mean to say by analysis of this, in our many of this literature, this has been elaborately mentioned. Analysis of case doesn't mean that whenever the case comes to you, prepare the totality and prescribe on that. Analysis of case means when you take down the case, when you confirm the clinical diagnosis, when you see all of the history, then try to find out what is the scope of homeopathy in it. Just now I told you that 3 cases. If that mouth ulcer case, that is traumatic ulcer, you are not able to heal with the homeopathic medication, whatever the medicines you are going to do. So I know that what is my scope in that, because that problem is a mechanical one, and that mechanical problem needs to be solved by the required interventions. In case of trauma, this trauma as well as the allergic rhinitis, both the things simultaneously we can't treat it. So first give the priority for the acute one, and then take the chronic thing into consideration. So analysis means we are identifying our scope, that what we are able to do in that case and what we are not able to do. You have a lot many experiences in the practices. Many times what happens, usually common people heard that for the piles, homeopathy has best answer. So many people comes to us, but we know that which are the piles which can be reversible, which are the piles which cannot be reversible. Many renal stone patient will comes to us that homeopathy has good scope in renal calculi. But unless and until we see the kidney function test, if there is an hydronephrosis, kidney is on the failure side, then don't give try to the homeopathy. At that time, that kidney preserving is most important one. If you are very sure that within the required time, within a specific time, if that stone you are in a capacity to dissolve, then only you take the time. Otherwise, you can advise the patient for the intervention, and after the intervention, you can make the patient understand that your tendency of stone formation is not going to be treated by any other system. It is only by the homeopathic medication. Then patient turns up by this surgical intervention. And this is my own clinical experiences. When you are very clear with the patients, many patients trusted on you, and they take your advice and they really comes after for your treatment afterwards. So analysis of case means you are understanding what is the scope of homeopathy, whether you are directly able to do some treatment for this patient or not. If I go back to my organon of medicine, it has been very clearly mentioned that our system is based on the natural principle. We believe on the dynamic derangement of the person, this vital force. That means we are able to heal only with the natural diseases. So apart from natural diseases, whatever is there, we have a very less scope in that. And that is why if you see the classification of disease, there is one entity is written, that is a surgical one and then the chronic one. And first is an indisposition one. So what exactly surgical means, which requires some intervention. So that poisoning cases, accidental cases where comminuted fracture is there, we are very helpless. And in that situation, we must take a call that what is the best for the patients. And then many times it happens that the case has reached to such a level that reversible pathology is not possible by any means. In that situation, what is our major role is to palliate the symptoms. I'm making it very clear. In that situation, our major role is to palliate, not to suppress. Now, palliation means just removing the more fasting symptoms of the patient. Usually in our practice, we get a cancerous patient with very offensive odor from their discharges or very severe pain from their internal pathology. These are the very common manifestations we are getting in the practice. In that situation, we should be very aware that what I want to do. Now, in that situation, we are able to find out organ-specific remedies or the local remedies or taking the totality of that sector only. And by that way, we are in a position to help the patient. And one more aspect which usually occurs in acute practices, that many times medicine is not needed. If you heard about what exactly is written in 150 aphorism of Organon, that is indisposition, just light alteration of daily habits that can impact on the physical health, and that can alter for time being only. For that, these dynamic medications are not needed all the time. That also we should be aware about it, so that directly we will not prepare the totality and we will not prescribe the medicine. So analysis is one of the very important part. Whenever any patient presented to us, after taking the case, after diagnosis, we should see what is exactly the scope in that patient. Then I go ahead, then I am able to find it. I must find out that what is the nature of this case. Now, for homeopathy, we have two varieties of cases as far as only homeopathic point of view when I consider. We have the acute cases and we have chronic cases. These are the only two type of cases we are having. Now, why it is necessary to identify the nature of case? When I label that this case is acute one, it means whatever the symptomatology I have to consider, I am very aware about it. Usually in my initial days of practice, what used to happen, if I am not able to differentiate acute and chronic, we take all the symptoms of the patient in our framing the totality, and by that we are not able to reach to the very correct matching medicine for our patients. Say, for example, I'm dealing with the acute ailments, any of the acute ailments, in that I found a very characteristic symptom, desire for sweet. But if this desire for sweet is present with the patient before that ailments, then it is not helping me to identify this acute picture of the patients. Now, in that situation, I must focus myself on all the deviations which has taken place acutely, which has taken place from that element when it is started, from its prodromal phase, whatever the deviation has taken place. One more very big misconception was there in my mind in the initial days, that for acute cases, only cause to be taken into consideration and only particular symptoms are to be taken into consideration. But through my own experiences, now I'm very sure that such is not the case. In acute also, you get the mental derangement, you get the physical derangement, and you get the particular derangement. It is not so that only particular symptoms are to be taken into consideration. Only thing one has to keep it in mind that if whatever the mental deviations you are able to observe, if they are the part of that acute deviation, they are only to be taken into consideration. Say, for example, we say that is belladonna. Belladonna is acute medicine, but actually it is not so. Belladonna is just an homeopathic medicine. But it has been observed in my own practice that whenever any belladonna painful condition arises, at that time, the state of mind of that belladonna patient, most of the time I observe to be a very violent, very abusive, using abusive language. So when I see this mental state, which has developed only after the development of this acute phase, then that is a real indication of this belladonna. This I'm talking about through my own experiences. It may be toothache, it may be a colicky pain, it may be a migraine, but when with the pain, this abusive language, irritability, violenceness, if you are able to see, then that is a belladonna state. So that doesn't mean that mental symptoms and physical symptoms appears only in the chronic case. It is not the thing. They can be seen in acute cases also, but we have to take care that I am dealing with acute case or a chronic case. If I am dealing with the acute case, then only I have to take into consideration all the acute deviations at all the level. Then your success rate will be more. I assure you, your success rate will be more when you are able to identify this. Then one more, chronic, everybody understand that they have this slow onset and continuous progress, and they are with the lifelong with the patients. And in the acute, we know that they have sudden onset, rapid progress, and there is a termination. That termination may be of either patient or of the disease. This used to occur. There is one third entity which H.O.D has told in his book, which I encountered into the practice. What happened in cases of bronchial asthma? A patient may landed in sudden asthmatic attack. Now, this asthmatic attack many times can be in danger to the life. So, any situations, if you are dealing with any chronic ailments, but if that chronic ailment is presented as any life-limiting situations, in that situation, chronic medicine doesn't work. You have to take that episode as an acute one, and then we have to prescribe the remedy. And when that acute gets subsided, then we have to go again for the chronic. And this acute attack has been occurred as a life limiting, that has been expressed in our organ as an acute exacerbation of chronic case. So actually it was a chronic case only, but in that chronic case, it occurs, one episode occurs which might be severely life limiting. In that situation, that has to be treated as an acute episode only. And for that acute episode, again direction to be followed same. Whatever the part of deviation of that acute state, based on that only medicine is to be given. If you prescribe only on that, then we get a more and more success. Now, I will just share with you a very interesting things. When you are dealing with this chronic case, many acute episodes comes. It depends on disease, and like bronchial asthma, it is there. Then urticaria is there. In case of dysmenorrhea, also it is there. You get an acute episodes on. When you are dealing with this calcarea carb as a chronic remedy, whatever the acute episode comes, most of the times they are taken care either by belladonna, either by Rostos, or either by bryonia. This is my own experience. And when I go back into the literature, at many places, these acute chronic relation has been confirmed through materia medica. Yes, if this is the remedy, most of their acute will be covered by such and such a remedies. And that relationship we are learning in materia medica. But when it comes to the practice, many times we forget. So you keep it in mind that whenever you are dealing with this acute, and when acute exacerbating condition occurs, directly we can't give the acute remedy of that chronic, because there are many more remedies. Just see what modalities, what local level characteristic symptoms appears, and that matching remedy is to be given. And it is likely from the group which is already mentioned in the relationship of remedies. So our half of the work has been done by all our pioneers, and we are very grateful for them that whatever they have experienced in their own practice, they have not taken. They have written as a part of their practicing experiences, and there we can collect all the things. Lycopodium we learn very nicely, but through my own experience, I understand that iodine is one of the best acute for the patient who has a chronic remedy as in lycopodium, and it has been mentioned in our literature, and that had verified many times into the practice. That is to be in a gastric ailments, right? That acute chronic relation in sphere of action also has been mentioned in many of the literature. Very specifically, if you go for the Clark dictionary, there this acute chronic relation sector wise has been mentioned, and that is really helping us in our practice. So this is one of the more important part as far as the case processing is concerned. Once you diagnose, once you analyze your scope, then you see whether the case I'm dealing with is acute or a chronic. If I'm dealing with the chronic case, then also I should be prepared myself whether this chronic case having any acute bouts, any acute episodes, it may come as in severe life limiting situations. Then you are able to prepare yourself whether such and such a things can happen, and that flourishes our practice. If we follow this system, then only it is helping us. So this is about the identifying the nature of case. When we proceed ahead, we say that we have a chronic case, we have identified the chronic case. Then what is most essential is that which approach is going to help me for this situation. That also we have to think of. Usual pattern of practice is that whenever we take the case and we prepare the totality, and that totality is only of the characteristic symptoms, that is how we used to be there. But here when when I'm writing that identify the best approach for this solution, I mean to say that you see which type of data is more into the case, and really that helps me in the practice. If you are able to see physical symptoms with mental characteristics are available, then in that situation really Kent repertory helps us wonderfully. And all those repertory which are based on the Kent repertory, they have their definite role in that situations. And when you have more and more physical symptoms concomitant with the physical ailments, particular symptoms associated with the physical ailments, in that all those situations, this Boger and Banu helps wonderfully, very, very wonderfully. They are helping to us. And there are certain conditions where we have the clinical diagnosis and few characteristic symptoms directly available, and which are just like a PQRS, what is mentioned in 153, that very few medicines has developed such a type of characterization. In that situation, we can directly go for the clinical approach. So when I say the approach, I mean to say that whatever the data available into the case, accordingly, we have to select by which we are able to find out the best medicines. That way, usually what happens into the practice, that I'm telling my own experiences. We usually believe on our memory that if this is the totality, then directly we are prescribing the medicine. And when patient doesn't give the expected responses, at that time we go back and to find out, we are finding that why this is not happening. Then we try to refer the repertory, or we operate the software, and in that software also we try to do the combined repertorization. I think these are the some things which is not helping me unless and until I clearly clarify myself that which approach will be best for me. That gives me a more and more results, and that is why we should able to see that what approach is going to give me the best solution. Next comes the analysis of symptoms. Now for this analysis of symptoms, again, one should be acquainted at least with the fundamental approach of homeopathy. We have in our repertory books and in organon books, lot many ways of analysis of symptoms. But what I'm recommending for best practice is fundamental approaches. And these fundamental approaches are given by only three persons, that is Kent, Dr. Boninghusen, and Dr. Bogus. These are the only three approaches by which every rest of the approach is accumulated one of the either of these approach. So analysis of symptoms is something else than the analysis of case. In the analysis of case, we are finding our scope, whether to take into for the treatment or not to take for the treatment. For surgical intervention first, and then the medication. First, palliative treatment is to be given, or a curative treatment is to be given. That is what analysis of case. Now, analysis of symptom is when you decide that I want to follow this Kent approach in this case, Boger's approach in this case, clinical approach in this case, then I consider the symptoms in their specific ways. That is what is called as an analysis of symptom. Say, for example, I thought that this case to be worked out by Boger's approach or the Boninghusen's approach. Then I will see the symptoms from location point of view, that which part is affected more. Then I will see the second component, that is a sensation. So this sensation doesn't mean that it is just a subjective sensation, but I will just see what is the pathology, what are the clinical manifestations there, means what affections are there. When I say location, means what is affected. When I say sensation, means what are the affections, whether there is a discoloration, whether there is a discharge, or whether there is ulceration, what is the affection. And then when I come to the third component, that is the modifiers, that by what these symptoms get modified, by in terms of either causation, either in terms of aggravation, or in terms of amelioration. These things I am able to observe in this. And along with that, when I see the fourth component, along with this, what more is happening into the body? And that is nothing but all called as a concomitant symptoms. Though the definition of concomitant, exact definition of concomitant given by Kent, that the symptoms which occurs with the chief complaint, which doesn't have a pathophysiological relationship. But when Boninghusen mean to say concomitant, is along with these affections in these locations with these modifiers, what more is happening into the body? Now, what more is happening into the body when you see this? And if really something is happening more into the body, that can be considered as an concomitant. And when you see these aspects, then the remedy findings become very easy by this approach, provided the case demands this approach. You cannot utilize every approach in every case. One should be very aware about it, right? If time permits, in future, we will talk on with the cases with all these things, right? But these things I should be very aware about it. When I think about the Kent way of analysis of symptoms, then Kent has given a very detailed, very nice explanation about the analysis. And if we follow them into the practice, then that really helps us. In the Kent analysis, he has given only two. That is, what are the general symptoms and what are the particular symptoms. General symptoms are for representing the patient, and particular symptom for representing the disease or representing that system or that organ. In that, only generals are having upper hand. And as far as this particular are concerned, in the particulars, whatever the characteristic particulars, they are having their role as to form the totality of symptoms. This is what the Kent way of analysis goes. And these general symptoms, then again he say that general symptoms are divided into, that is, mental symptoms and the physical symptoms. So like that, we are able to see that mentals, physicals, and characteristic particulars. This is the categorization. This is the analysis as far as the Kent is concerned. So that way you should do the analysis of symptoms. Of course, this, when you are sitting in the chamber, when the patient is in front of you, these things get automated in your mind as you go on with the experiences. But if you want to learn, as far as my own experience is, this has to be done on paper. When you do certain cases through these practices, then automatically these things happen as a part, as a reflex of your body. And then immediately you get the real totality. But your mind should pass through each of these steps. Then the last step comes before the totality formation is evaluation and symptoms. And I think this is the most important part of the homeopathic practice, which I'm not claiming that nobody follows. Everybody might be following, but there is a difficulty in understanding the evaluation of symptoms. In our books, in our literature, in our commentary of given by the different authors, Everybody is talking about the evaluation as a comparative importance of the symptoms, which symptom is more important, which symptom is less important. Lots of commentary has been mentioned, but hardly any author is talking about how exactly evaluation is to be done. And I experienced from my own multiple cases that evaluation to be done by only three parameters. And those three parameters are nothing but first one is the intensity of the symptoms. I'm making it very clear again. Evaluation of the symptoms is done by only three parameters. I'm very sure about it. First is intensity of symptom. Second parameter, how deep seated it is coming out from the organisms. And the third parameter comes, that is how peculiar this symptom into that patient. These are the only three parameters by which you can comparatively judge that which symptom is more important and which symptom is less important. And when you do the evaluation, then automatically the symptoms which are more important, they are at the upper hand. Very obviously they comes at the upper hand. It seems to be a very lengthy exercise, but once you do the 10-20 cases by your own hand, then automatically as a part of reflex they started, and the real cream of totality formation comes up. Now totality formation is not a process. When you do the evaluation, automatically totality get framed. This is my own experience. For totality now, no need to do the efforts. You have to do the effort to understand the comparative importance of the symptoms, and that is nothing but the evaluation. Once again, I'm narrating these three things which are most important part of evaluation is the intensity of the symptom, peculiarity of the symptoms, and how deep seated these symptoms is coming from the organisms. And this deep seatedness has been reflected in our literature as a grading of the symptoms, that is grade 1, grade 2, grade 3. But if you are doing only grading and preparing the totality, means you are doing 1/3 job only. If you are not taking into consideration the intensity and peculiarity, right? That gradation has been there in our literature, but this gradation is to be added with the intensity and peculiarity. Then your evaluation will be proper, and you are able to identify the very proper symptoms, which can be a part of totality of symptoms. Yeah? And if you follow this step, then automatically this totality get prepared. After totality formation, we have to go immediately for remedy selections. Of course, everybody will say, yes, it is. Nowadays, it's very easy because so many software, so many applications are available. I hope everybody is following me.
Yes, sir.
Yes, sir.
So after you frame the totality, what are the steps which are needed to be followed? So when you prepare the totality, it is an automatic part. As in the evaluations, you will see which are the top priority symptoms are there. You are taking into the totality. Now, for that symptoms, you should find out a proper rubrics in whatever the repertory you are using. That we technically called as a repertorial syndrome. Now, this repertorial syndrome is very, very important. Many times what happens, whatever the symptoms we take from the patient, and when you go into the repertory, in the repertory, these headings, rubrics, or the terminology which has been used, it needs to be understood from that reference point of view only, not from our own reference point of view. Whatever way this repertory has been created, I will tell you on my own experiences. So if you see this dinner and lunch, we have these two common words in our common English, and we take the information from the patient also. So many times we consider dinner as the meal which is taken in the night time, and lunch we consider as the meal which is taken in the daytime. But if you see from the Kane point of view, where this rubrics or this words has been framed. So dinner means the principal meal of the day. If you see this dinner, then it means it is a principal meal of the day. Now, as far as this Indian scenario is concerned, when we take the principal meal of the day and when we take a short meal of the day, that varies as far as this repertory is concerned. So When I say dinner, it means the noon meal as far as India scenario is there. And when I use such a symptoms in that interpretation way, I get more and more results, right? So what I mean to say that whatever the symptoms you are taking in totality, for that appropriate rubric should be understood. And if we are not very sure what is the meaning of this, don't feel shame. Open the dictionary, try to find out the meaning through the dictionary. And once you convince, then only take that. Otherwise, you are very likely to miss the required corresponding remedy for your patients. So this repertory syndrome is a very, very important step. Many times what happens, for one symptoms, you never get a direct rubric into the repertory. For that, there are some certain techniques in the repertory that you can permute the rubric, you can combine the two rubrics, right? So that way we can use and we can get the appropriate corresponding rubric for our symptoms. And hence, this repertorial syndrome is one of the important aspects. I remember our teacher used to tell us they are verifying our repertorial syndrome. We are not very serious at that time. But now when we enter into the practice, we understand, yes, really, it was a really very, very important aspect, repertorial syndrome. For that, you should be well acquainted with these various rubrics which are presented into the repertory. What we understood as a permutation of rubric, combination of rubrics, which two rubric if I combine, then I will get the desired symptoms which is there. And then when to use the cross repetition. This is also one of the very, very important aspect as far as the practice is concerned. And then we should also get acquainted with these clinical repertories, that what are the rubrics mentioned over there, which clinical conditions are mentioned over there. Along with that clinical conditions, what are the other associated modifier factors are there in the sub-rubrics of all those clinical repertories that we need, so that we can have a best cross repetition and we can get the desired repertory. Of course, this is a time consuming, but once you go on experiencing, practicing this, I assure you that you will get a better and better result than the previous one. When you follow these steps, this I'm talking about from my more than 20 years of practice. Then we do the actual repetition. Many times we think that a repetition is not needed based on our memory, by own knowledge of materia medica, or by my previous experience of the case. I just prescribe the medicine, but many times it comes to be failure. Whatever the strong memory you are having, whatever the sound knowledge of materia medica you are having, I will insist that if the time permits, you should go for the repetition. And you see, by going through the repetition, you get very unusual remedy. Unusual remedy, I don't mean to say that that remedy is not known to you. I remember a case of fever. Many times, many remedies has been given, but it was not responding. That patient used to get the fever only in the evening. A very specific time patient told me. But we hardly do. But when I do the actual repetition, remedy comes to be creosote. And it was the only two remedies were there in these three rubrics of whatever the totality I had prepared. One was the cephalinum and one was the creosote. And I remember that patient previously comes to me for the treatment of some menorrhagia, and at that time I had prescribed this creosote to him. Now see, creosote remedy I know, but what happened with my own prejudice, I limit creosote to just to female genital organ or the GIT aspect only, or to some of the intention of the skin elements as it is prepared from carbon and this carbonated hydrocarbons. I limit. But when you do the repetition, it explores my area. So though you are very sure that out of these three symptoms, only this remedy can be covered, but you go for repetition, you will see some better remedy which covering the larger aspect of this. So never ignore this aspect of actual repetition. Right? Many cases has been given a wonderful by common remedies which I never thought of. Then when you see this result of repetition, at that time, which remedy to be selected? Take a pause. Top mark covering remedy should not be given all the time. Take a pause, go back to the case history and see the whole portrait of the person. Many things are there which are not a part of totality, but still they are very significant as far as the patient case record is concerned. So when you look at the case record, many things remains over here, like many of the symptoms which are not become a part of totality, though they are very intensified. But as they are very common to the disease, so we never give them the due importance. Then some major data into the past history of the patient. That also provides us a very good information as far as remedy selection goes. Then the miasmatic state of the patient, then the thermal state of the patient. These are the things which never become a part of totality, but they are also one of the significant general aspect of the patient. And these general aspect of the patient should be matched with the medicine. If it is matched, then that gives some fantastic results. This is how the practice increases, result improvises. And then lastly comes the appropriate remedy with the dose and potency. Now everyone knows that how to select the dose and potency. In my own experience, I had seen that it changes from door to door from every physician, right? But what I learned from my own practice is really what is written in our literature, that is a susceptibility criteria. Now the question arises that how I will came to know what susceptibility, how to judge the susceptibility. These are some of the important aspects. But when you read this susceptibility, it shows only through the manifestation. As we have seen the miasm, how to identify the miasm, it is only through the manifestation. Similar way, susceptibility is to be understood through the miasm only. Many of the times, as I remember my olden days, I had very fixed ideas that susceptibility is very high in children, very low in old age, moderate into the young age, right? It was there in my mind. But as the practice goes on, I'm able to find out if I'm dealing with this case, how many characteristic symptoms are available, at what level they are available, mental level, physical level, or a particular level. If they are available more on the general level, it means susceptibility of the patient is very high. It's trying for the symptomatology, showing us the data to help the patients. So that way, through manifestation, we must be able to understand the susceptibility. And once the susceptibility is understood, then it becomes very easy for us to select the dose and the repetition. We know that susceptibility is just in reactivity. If reactivity is high, it is always everything is inversely proportional. We have to go for high potency, but do not repeat too much. And if susceptibility is low, it means patient doesn't react. So if patient doesn't react, I need to give hitting again and again. It means it requires some repetition. And so if I want to repeat, obvious that I will use the low potency. So this is the general guideline which I had experienced in my practice, and so I am sharing it. And this is how the remedy selection with proper dose and potencies to be done. Now, my job is done? No. I think I'm having a time, no? Though it is 8:30.
Sure, sir. Please continue, sir.
Yeah. So I will just conclude within short time. So after remedy selection, proper prescription, the best part of practice or charming part of practice comes as a follow. Now in the first follow, what is to be seen? Right? It takes me years together to understand what is to be done in the first follow-ups. Every time I used to see that whatever the symptom patient having more bothering, whether they are elevated or not, Many times it happens that they are not elevated, but rest of the things has been better by the patient. And I'm not able to interpret what is happening to this. But that shows me is exactly written in our organon that if patient on a general level feels better, wait and watch. So see what general level patient is having. So whatever the generality we are taking from the patient, if any alteration we have observed in all generalities, and if they are improved, then you are very sure that you are on a very right track. Though I am dealing with the case of migraine, and in that I observed that patient's sleep was disturbed, and now after giving the XYZ remedy, migraine is as it is, but now patient is getting a good sleep, sound sleep, refreshing sleep. It means on the right track. These generalities is to be observed first. And when you see these generalities are improving, it means patient is going to be improved. Do not disturb at this level to the patient by giving extra dose of medicine, by changing the medicine, by rethinking of the medicine. Don't go by this way. So these are the very important aspects that what to see and how to interpret about that. Many case scenarios are there by which you will decide that what to consider this and what not to consider this. At many times it happens that generalities we are not able to interpret, and we see the local symptoms are not relieved, and so we are all the time changing the medicine. So this should not happen, right? So these are our common mistakes into the practice. We should take care of this. You understand whether if the patient is at general, if he is improving, changes are observing at the general levels, then you are on the right path. Just give time the medicine to act. Many times then with the practice it happens that you are giving the medicine but the things are not happening on its way. Then the different approaches comes in our mind, that when no sod is to be applied, in which situation organ specific medicine is to be applied, when external applications are needed, when mother tinctures are needed. They are also the part and parcel of our practice, but each of these have their own indications. Organ specific medicines, I observed that they are most useful when your intention is to just palliate the symptoms, just to palliate the symptoms. You can't take a disadvantage of such a remedies as a part of your practice, which usually happens into the practice, but I will condemn that this should not be happening. Right? Mother tincture, when they are indicated, when organ stimulating remedies you require, they are to be given in the form of mother tincture, then that gives the best results. Many indications are there in our literature as to which mother tincture acts on which area, at what time it is to be given. Right? Everybody knows about very common, that is alfalfa mother tinctures. It's really very good medicine to bring back the vigor, to improve the appetite of the person. But it has its own indication. Unless and until you get that indication, don't use roughly for any patient who want an appetizer for his practice. Right? Many times China also do the same job. When you take the totality, if you see that what has happened to the patients like that, every time mother tincture doesn't help. But I do agree that mother tincture also having its own role in its own indications. Like that, this organ specific remedies, no source, intercurrent remedies, every remedies, every areas, whatever is mentioned in our literature has its own scope. Then just before also I talk about the understanding the remedy relationship. It is one of the most important aspect of homeopathic practice, but don't bother about it. As you give the one remedy, and in that relation, when you read the rest of the remedies, then you are in a position to understand that remedy very well, that in which aspect it is complementing, in which aspect it is antidoting, in which aspect it is inimical. They are need to be understood. This practice will teach us, provided if you follow all these steps. And these are to be considered, these steps to be followed, still complete recovery of the patient has taken place. And what that recovery, that our analysis of case will decide. In the analysis, we have decided our a target, that this case is completely reversible or not. This is just palliation required or not. Right? So that analysis of case will decide that when to stop the medication for this patient. And when this happens, then this is really done situations. So I end my my presentation over here. I'm very sorry that I'm not able to tell you more and more cases. My intention was just to tell you the rough idea that what way I'm practicing, what way I had used my experiences. For that, these are the some books references which are helped me very nicely to improve my knowledge. Then lastly, I'm thankful to these people who has really given me the support. And so before concluding, I just want to ask, anybody wants to add anything to this presentation to correct me, or if you have any query so that we can talk with one another and get it clarified. It's over to you.
Thank you, sir. Thank you so much. The extensive session, sir. Over to you, Ashita.
Hello.
Yes, ma'am. If anybody is having any query, any things to want to add, that will be very good for me.
Session. Sir, and insights about acute and chronic cases were also amazing. And sir, insights about homeopathic materia medica, the posology, the totality of the symptom, and everything was literally very helpful. Thank you so much, sir.
Thank you once and all for all of you. Thank you for giving me the opportunity. Thank you.
Thank you, sir. Respected participants, if there are any questions, so kindly comment in the comment box so that sir will be answering.
So anyway, if you have any query, you just bring back to me. Okay.
Definitely, sir. So thank you, sir. Thank you so much for the extensive session, sir.
Okay. Thank you. Thank you.
Thank you all the participants. Looking forward for many more.
Okay. Thank you. Bye.
Thank you, sir.